Welcome to the IGR 2025 chemo course, and I'm delighted to welcome you to the debate session on the topic of gynecological tumors today. And I'm delighted to welcome my colleague, Dr. Patricia Potier, who is also from Gustave Roussy, so that we can discuss some of the more controversial topics. Because sometimes our study results do not only provide answers, but sometimes also questions. And so the two topics we chose to debate with you today. The first question is, in light of the negative overall survival data from the PRIMA study, how do we know to whom or whether to give a PARP inhibitor alone as maintenance in the first line? And then I will have a question for my colleague regarding cervical cancers. We have two positive trials for locally advanced services. So how do we choose the best strategy? We have the option of induction chemo, we have the option of radio chemo with Pembro. And so that's what we are going to discuss today.
So for the first question that raises the issue of PARP inhibitors as a first-line treatment in ovarian cancer, we already had survival results for the mutated patients with olaparib, and then in combination with bevacizumab in the PAOLA trial for patients with an HRD tumor. So what to take away from these eagerly awaited results? Niraparib alone as maintenance after chemotherapy in first-line ovarian cancer.
So we didn't really know what to think, actually, because the initial results that were presented were with more hindsight. Still the benefit in terms of PFS1, the first PFS. And there, as you can see, if you take the overall population, there is always a better PFS for the arm randomized to niraparib in maintenance for 3 years. This benefit, clearly more significant in HRD positive cases. And by the way, today with more hindsight, as much as in the early publications, we saw a small benefit in HRP cases. Now this benefit seems to be gradually disappearing. But again, here, it's about progression-free survival. And as we had studies, as Patricia said, with positive overall survival in SOLO-1 and PAOLA, what are the results in overall survival for PRIMA? Here, if you take the overall population, that includes all patients with mutated BRCA, wild-type BRCA, positive HRD, negative HRD. No difference in overall survival, even with good maturity, at more than 60% of events in this population. But that's in the overall population. So maybe there's a difference depending on their molecular subgroup, and then surprising. So you see the difference in overall survival that I just showed you overall, meaning in all patients. But then when you look at the difference between HRD and HRP, there is no difference in overall survival, but really for the HRD, the two curves are on top of each other. So truly, absolutely no benefit in overall survival, although I remind you, for PAOLA, there was a benefit in overall survival. When you consider the overall population, there was a small benefit, but we recall that in PAOLA, the HRP, the beva in the control arm works quite well. But even in PAOLA, there was still a small separation of the curves. But above all, we see a nice separation of the curves in PAOLA for the HRD population. No benefit for the HRP, but clearly a nice overall survival benefit for HRD tumors. Whereas we don't see this at all in PRIMA.
While we recall that the control arm in PAOLA is still better than the control arm of PRIMA.
Yes, it's a good asset.
As it includes bevacizumab. So we could even wonder if we had compared with bevacizumab, if the study might not have been negative.
Harmful,
there you go.
Yes. Can we try to understand this difference between the positive results of a PAOLA? One of the things is there is an association in PAOLA. So does adding beva with PARP actually increase the benefit? But we must still remember that there was a difference in population in the PRIMA study. It was only patients with poor prognosis. They had to have residual disease or required neoadjuvant chemotherapy. So by definition, this is for high-risk patients whose progression-free survival is going to be shorter. Also, they didn't have 2 years of PARP, but 3 years of PARP. And that's important because actually, when you look
when you reach 36 months, you see that even in the experimental arm of niraparib, at 3 years, 70% of them had already relapsed.
So what does that mean? It means that most of the patients who were in PRIMA, even in the experimental group, relapsed under pressure
Of a PARP inhibitor. And are we starting to have hypotheses that it could be important? So this graph is a bit complicated, but the information is honestly very, very important. And that, Paula taught us.
Paula looked at patients who in the experimental group relapsed under PARP, so during the first 2 years, versus after having stopped their PARP later. When platinum salt was reintroduced, how did they benefit from the platinum salt? Well, there you can see that the red curve, progression during olaparib, well, the platinum does not work well.
While for those in yellow who progress after PARP-peak, or those who were in the control arm, platinum works just as well.
So clearly the effectiveness of platinum is maintained if we progress post-PARP, but it's probably compromised if we progress under PARP. So in conclusion, first, we are still worried. We saw zero benefit in overall survival, probably because many of them progressed under the pressure of a PARP inhibitor, okay? And probably this induces cross-resistance to platinum. Patients whose primary diagnosis, as I told you, had poor prognosis, were receiving the PARP for a longer period. As a result, in the majority of cases, they progressed under PARP pressure. What do we do with this data now? Shouldn't we do 3 years of steps, then rather 2, because we especially don't want her to relapse under the pressure of the PARP?
As soon as I have a marker that goes up now, I tend to stop the PARP. Patricia, what do you do with this data?
It's a bit of a bother for me, especially since we don't have that data when there's a relapse, because niraparib, when given during a relapse, is somewhat special because we select the patients. About the response to platinum-based treatments, particularly in the arms, in patients with a BRCA mutation, we were not shown the results during the session at the European Society for Medical Oncology, but they are in the publication. The population of mutated patients does not benefit from first-line niraparib in this study. However, in recurrence,
she benefits
when selecting
from it.
patients based on their response to platinum, they benefit from niraparib. So it's a bit difficult, and I agree with you, we probably need to give a bit less PARP. In the first line, and especially stop as soon as we feel that the patient is no longer responding, the disease is escaping the treatment.
And I take advantage of it. To remind that result, we still need studies, and to recall that this study is ongoing Nirvana, which asks the inverse question of Paula, who basically says, everyone can receive an allocation limiter for a first line if it is in response.
Here, it only focuses on patients in surgery, zero cost to start with. And the question is, which ones need, beyond the PARP, to also receive beva? So the randomization here is niraparib alone versus nira plus beva. So a reminder, very important study so that we can better understand. Because I think today, we still don't completely know what to do.
Now, I will hand over to Patricia and ask, what should we do now for our locally advanced cases with 2 positive studies? So how do we choose? Thank you, Patricia.
So first of all, it's good to have 2 positive studies.
Well, it's a rich
It's been a long time since we've had, positive studies in cervical cancer. I remind you that locally advanced cervical cancers represent a very large population of one. A tumor that can be small in size, but with lymph node involvement, which of course worsens the prognosis, or without lymph node involvement, but very locally advanced. And that still changes the management. And the classification, there I reminded you of the classification, which is very difficult because in studies, the classification used must be carefully verified. The latest classification is the 2018 one, which incorporates lymph node involvement in the classification, which was not the case in previous FIGO classifications. So in the end, the easiest for comparing all the studies is the TNM. Because here we have the classification, we have the tumor size, locoregional extension, lymph node involvement, and metastatic involvement. But you have to be careful because they are not all comparable. The studies are not all comparable because of that. So I remind you, these are the latest recommendations from the St. Paul Devance courses that were made last week. We have an update, even more than an update. We have incorporated in these recommendations the management of localized cervical cancers, whether they are small cancers or locally advanced bodies with quite significant levels of evidence. So the standard treatment for locally advanced forms remains up to T4M0. Regardless of the lymph node involvement, external radiochemotherapy with concurrent chemotherapy and an image-guided brachytherapy So here the doses are reminded to you, modern techniques. Normally in France we can use modern techniques, and that's what will likely change the interpretation of the studies. And then there are these two studies. The first one is Interlace. It's incorporating a very short induction chemotherapy. 6 weeks of platinum association, weekly Taxol, and in the 7th week we do radiochemotherapy in patients who have a localized form. They may have lymph node involvement, but only pelvic. Lombo-aortic lymph node involvement, so the 3 C2s in the latest classifications were excluded. And we will notice that in this study there are still many localized stage 2B forms. With or without lymph node involvement. It should be noted that there is more lymph node involvement in the chemotherapy branch 1. So it's a large, essentially English phase 3, but there were also patients from South America, and it was very simple. Induction chemotherapy, radiochemotherapy in the 7th week versus radiochemotherapy, which has just been published in The Lancet for locally advanced forms, without lumbar aortic involvement. And we see in this summary of the results, we have a benefit in terms of progression-free survival and also in terms of overall survival, with a difference of around 8% with identical local control, which is important. So there is a reduction in the metastatic risk with this small induction chemotherapy. 8%, that's what we get by incorporating platinum into the chemoradiotherapy. It's about the same results, so it's important. So the criticism from our radiotherapist colleagues is the external radiotherapy techniques, and especially brachytherapy, which are a bit less modern than what we can use, for example, in France, but it's the same techniques in both arms.
And then somewhere the trials that prove the benefit of cisplatin had the same
and then
issue.
you have to see that all over the world, we do not have access to hyper-modern techniques of radiochemotherapy like we can have in Europe. So this benefit should still be considered in addition with a cost that is quite low and feasibility that is still quite simple. However, it is necessary to strictly adhere to the protocol, that is not to do not delay, in quotes, finally.
It's not neoadjuvant.
It's not neoadjuvant, it's very short. And there should be no interval between the end of the last injection and the radiochemotherapy. But this study, it deserves to exist in a common population. That is, there are many 2B. And much less of 2B, as we will see in the second study, which was chemoradiotherapy. This second study is the study with pembrolizumab. It should be noted that there were still 2 phase 3 trials. So it's roughly the same indication testing immunotherapy in combination with radiochemotherapy. A randomized phase 2 trial, which is atezolizumab, whose results we will have at ESGO. So the first study is CALA with durvalumab, 24 sites, and the main objective, PFS, which is negative on PFS. There is no increase in PFS with durvalumab combined with radiochemotherapy. This is important. Important with inclusion criteria that are roughly similar to those of KEYNOTE-A18. So it's the one that is positive with pembrolizumab, 20 cycles, with a dual and we have roughly identical populations if we take the FIGO 2014, so without lymph node involvement with stratifications on the early stages versus the more advanced stages. You see the results of KEYNOTE-18, which is a positive trial with a reduction in the risk of death in this population, a hazard ratio of 0.67 on survival. And so if we look to the right at the subgroup analysis, we see that the population benefiting most are stages 3 and 4. So these are either locally advanced, very advanced stages, or tumors with lymph node involvement. On the other hand, stage 2, the 2B in particular benefit much less than what we can see in Interlace. So this study received approval in the United States and now in Europe for stages 3, 4. There is no authorization for stage 2, N0, or N+, since it is FIGO 2014. So basically, to summarize, there would be a place for induction chemotherapy for FIGO 2018, either 1B, 2N+, or 1B, 3, 4A, except for stages 3C2. That's what's. And for patients who would be candidates for immunotherapy, at that point, induction chemotherapy is not recommended, meaning for stages 3, 4. basically 2C. And from 0, earlier induction chemotherapy is still much more common, N0 or N plus pelvic. And then for the others, at that point, immunotherapy is for either very, very locally advanced forms, bladder or rectum infiltration, or patients who have nodal involvement up to the para-aortic area. It seems that the forms with a bit higher risk of metastasis would benefit more from immunotherapy than the more localized forms.
But we have no proof that for the surgery that combined immunotherapy, chemotherapy really perform better than induction followed by radiotherapy. We don't know. That we don't know. You have examples of locations like head and neck tumors. We have another study with Shikella where combining immunotherapy, chemotherapy does not provide benefits. So in immunotherapy brings.
Stage 3, does combining immunotherapy with chemoradiotherapy really perform better than induction followed by radiotherapy? We don't know. That we don't know. We have examples from other locations like head and neck tumors. We have another study, which is CALA, where combining immunotherapy with chemoradiotherapy does not provide benefits. So it may be immunotherapy that brings, which is done in consolidation, that brings benefit. So there are currently studies that test rather the neoadjuvant and the adjuvant without doing immunotherapy.
Of concurrent occurrence?
With chemoradiation, like the Colibri-2 study that just started in France.
And then other studies with surgery, for example, where we do it in neoadjuvant and adjuvant, but we do not do it with radiotherapy. Okay. I think it's really important to point out because I've seen misunderstandings that it's not neoadjuvant, it's induction for 6 weeks only. So that's chemotherapy. However, when doing immunotherapy, we are obliged to follow this study at 18, meaning to do it with radiochemotherapy, then in maintenance afterwards.
So too many options. What's great is something that we didn't include for our cervical cancers before. In any case, thank you very much for joining us for this debate on gynecological tumors that are integrated into the Gustave Roussy chemotherapy courses 2025. And don't hesitate, you can find the courses as well as this debate online on the site mentioned. Thank you very much for your attention and have a good end of the day.